I'm going to discuss a little bit about research into polycystic kidney disease. I'm going to try and there are massive amounts of research going on all over the world in relation to polycystic kidney disease or cystic kidneys in general. A lot of it won't be of any use to you. For instance, the green building you may have seen as you came in is a mouse house, the Huenel building, that's full of mice. All of that stuff is kind of a decade before becoming anything even remotely clinical, so I've avoided all those type of things. I will talk a little bit about basic science, so that's fundamental science, very briefly about the things that are going on, particularly in Australia and locally, and also some of the clinical trials, which will be perhaps more useful to give you an idea about what's happening on the horizon in terms of treatments that might be coming up. So I'll start with water because I think this is kind of one of the big polycystic kidney disease trials that's happening in Australia at the moment. I'll talk a bit more very briefly about tolvaptan, lixivaptan, which is similar to tolvaptan, and that's currently going through trials. Another one, butoxylene methyl, and then KidGen and CCG are both two genetic studies. That one across Australia and one is local in Canberra, so it might be a bit more relevant for people here. So, tolvaptan, the medication that I mentioned, lixivaptan, which is kind of the second generation, another new version of tolvaptan. The way they work on is really a receptor that your body uses to associate with thirst. And so when you're not thirsty, this hormone goes down and tolvaptan blocks that hormone. So one thing that's been recognised for quite some time, or thought about for some time, is that if you drink a lot of water, and we've had this discussion about having to keep your urine at a very dilute, drinking so much, almost 3.5 to 5 litres. If you keep drink your water and keep it to your urine concentration is very low level, so you're very, very well hydrated, this hormone switches off. And so the theory is that switching this hormone off is almost the same as taking the tablet which blocks the hormone. So rather than taking this medication which can affect the liver and cause other things, what if we just drink so much that our body switches off the hormone? And this is actually a clinical study to see whether this much cheaper, much, in theory, simpler trial could be effective. So this study, PKD, is running around Australia, across Australia, multiple centres. We're actually trying to get it up here as well with Gopi, who's the lead author on it. So what the study is a prescribed water intake to prevent kidney failure. So they're aiming to recruit about 180 patients under the age of 65 years. Kidney function has to be above the 30 mils per minute. And the reason for that is if you're kind of at 20 mils, there's not much room to preserve. So we want to follow up for about 3 years to see whether we're going to be able to prevent progression of kidney disease. The way it works is actually the study's reasonably intensive. You have to meet with a dietitian. I think it's every 4 weeks or so they've been contacted by one of the research staff. Meeting the research staff every 6 months. We take a whole range of different measurements of kidney function, blood, and then we do questionnaires about whether people can tolerate drinking water at high volume. We measure your urine to see whether you need to drink more or less, and teach you how to measure your own urine just to make sure that you're keeping your fluids up adequately. And really what the goal is, as I mentioned before, the sizes of kidneys with polycystic kidney disease really is very strongly associated with progression of kidney disease. So yeah.
What are you measuring in the urine?
Osmolality. So osmolality
is just like you can get a pH test?
Yeah, so there's these dipsticks where they can measure osmol, the urinary dipsticks, so you can measure your osmols. And so they give you a range, and as long as it's under the 300, in this it's less than 270, but if it's under 300, then you're on target. Yeah. And because getting there is easier said than done, unfortunately. It's good, but it can be brutal. So I'll come to that. That's one of the big outcomes we're looking for, is where it's even tolerable. So we do MRIs at 0, 18 and 18 months and 3 years, and we're just looking for if you have keep your urine very dilute, does that slow growth in the kidneys compared to people who are just drinking normally? Some of the other outcomes with that is the tolerance of the consumption, because it's a big volume, it's a lot of water, it's every day. It sounds like a good idea, but I could imagine it would wear very thin on many, probably after the first week, to be honest. But going into it, trying to drink and be very meticulous with it will be quite difficult. Measuring kidney function, obviously, because if you can see not just a change in the kidney growth, but also preservation of kidney function, that's really the thing we want to see. We're looking at blood pressure and then safety, because if you drink copious amounts of water, there are other salts and electrolytes in the body that can start to become depleted. People can actually get a phenomenon called water intoxication. So, and that's something that Olympic runners, long distance runners, when they drink too much water and don't have electrolytes. So these are some things that we'll continue to monitor over the period of the study. I won't ask. So yes, recruiting across, there's a lot of centres in Sydney, Queensland, I think there's also some in Perth, Victoria, and we're in kind of discussion to try and get it up and running in the unit here. So this is just this is from the Polycystic Kidney Foundation, so this is kind of the American equivalent of the PKD Foundation in Australia, and they've just been registering some of, this is not all of, but some of the big trials and the centres which are participating in them. And I just want to give you just a little bit of a snapshot of kind of the global activity. And these are big trials. There are a lot of small trials going on, a lot of small studies across, pilot studies, kind of idea-forming studies. But you can see North America, very active, Europe, very active. So these are both centres, and this comes back to this question about why the rate's so high, because they're much more interested, much more active in research and diagnosis and things like that. So across US and Asia, a couple of things to mention. So tolvaptan, which I mentioned, there have been two very big trials which essentially showed exactly the same thing. There was a reduction in kidney size, small, but there, and a modest but present reduction, preservation in kidney function. And so a lot of people now, often with us, it's not black and white like that, so we say, are there particular people that would benefit more versus others? Not all comers, but are there individuals who disease progresses faster, so if their rate of decline is a certain percentage, or the growth of their kidneys is a certain rate, and we say that's too much, do those people particularly benefit? And so there are at least 8 different trials across both Asia and North America and in Europe, which are quite large size, which are looking at different variations of tolvaptan. Are there different ways that you can use it where it's safer from a liver point of view and less of the side effects with thirst? And other ones where are there particular individuals where they particular genes, particular individuals where it is especially useful. So the first trials just showing that it had that benefit were really kind of the first step, and now there's a lot of work kind of teasing out who will really benefit a lot from this medication. Lixivaptan is another version of tolvaptan, slightly different. Really, it functions the same way as tolvaptan. The drug company's kind of hoping that because it's a slightly different compound, it may not have a side effect profile, maybe better. And so they're running a couple of trials, particularly across North America, to see whether this drug is going to be superior or equivalent to tolvaptan. There's this other interesting one, which is butoxylone methyl. To be honest, I didn't really even know about this compound doing the rounds until maybe about a year ago. They've tried it in a number of kidney diseases, both in polycystic kidney diseases and outside polycystic kidney disease, but all in kidney disease. Now, there have been 2 big trials outside polycystic kidney disease. One was for, I think it was IgA, anyway, for a different condition. And what they found was that some people had a kind of quite an adverse reaction to the medication, had to stop the study early. The second study was looking at a condition called Alport's syndrome, and what they actually found was it was very potent in, it actually had the ability to increase the kidney function, whereas those not on the medication had a reduction in kidney function. They had kind of learned from the first study, and so they didn't have as many side effects in the second study, and saw quite a significant difference between those that were treated and those who weren't. So I think they've taken the info from the very first study, it was heart problems, heart failure was the issue, and now they're testing this across multiple centres in North America and trialling this agent and trying to preserve kidney function. And we'll probably find out about the butoxylone methyl. I think that, it's supposed to be 3-year follow-up. We'll probably find out about that in another 2 or 3 years as well. And then there's another compound which doesn't even have a name, it's so new, so I just throw it in there to mention for completeness sake. I'd like to talk a bit about some of the things that, some of the research that may be personally applicable and also of interest to people in the audience. And so, while there is a lot of basic science going on, the ones that are most applicable are going to be around genetics and the genetics of individuals. So there is a consortium, the KidGen consortium, the Kidney Genetics Group. So they're run out of a group at the Royal Brisbane and Women's. Their interest is in inherited kidney disease, specifically a particular interest in polycystic kidneys. They have collaborations in clinics all over the country. Essentially, their goal is to improve the understanding of inherited kidney disease. Most of the centres, what we can do is we take individuals who are with a new diagnosis or a family who may not have had genetic testing, and then for KidGen, they are referred to Westmead Hospital where they will undergo genome sequencing, and then depending upon if it's a kind of a classic form like the PKD1 or PCKD2 genes, then that's just passed back to the clinician and we can say, look, we think this is the mutation of interest. If there's something else that's not known or that's new, then that is then passed on to researchers who may then start to do some form of lab research to kind of understand what might be the basis of that disease better. Which is what I just said. I should mention, so of those particularly based in Canberra, we have a very similar thing here. So I work as a kidney specialist at Canberra Hospital. I also work here in kind of in precision medicine field. So a number of things, but basically it's based around genetics, essentially based around genetics. So we now have a facility, it's been up for 2 years, a new service in Canberra Clinical Genomics, which is offering sequencing for any kind of genetic inherited condition. So any doctor, actually, or any doctor anywhere as far as I'm aware, but particularly in the ACT, can refer a patient for genome sequencing if they think it's indicated. You see one of the physicians or the scientists there and they'll do an assessment, and if they agree that there's a role for genome sequencing, they will organise for a whole genome sequencing to occur. Now, so we'll either get a report issued which says, you have PCKD1 or 2 or whatever is going to be your gene. If they don't find anyone, you fall in the 5 or the 10% where we don't actually find the gene, then there are a handful of clinicians who work with genetics, and I'm one of them, where the genome can come back and then we can say, look at the genome and say, is there something else here? Is there something novel? Is there something that we can do or investigate or research? And so that can happen here. So any physician in private or public has the capacity to do that. Refer to Canberra Clinical Genomics, and from if there's not one of the classic gene variants, then that typically falls on my desk to try and figure out if there's something we can do about it. Okay, and so from the Canberra Clinical Genomics point of view, the point of it was to cross over between both clinical genetic diagnosis and then from a research point of view. So that's just Canberra Clinical Genomics, and the pictures of the building that you're sitting in, obviously, but it's actually based over at ACT Health. And just the last thing I mentioned for local research is the research fund we have here, and I'm just plugging our local area research fund shamelessly, but we do have a research fund which is dedicated to investigate for basically precision medicine for a number of genetically based kidney diseases, and that's based here at the medical school and supports research here at the hospital. So you can look it up and it's tax deductible, etc. Any questions at all about that? Yes.
What's the number of people in Australia that have PKD per 1,000?
So I think the numbers, the autosomal dominant PKD per 1,000, the prevalence is going to be a lot higher than 1 in 1,000, but I wouldn't be able to quote the number right off the top of my head for you. Most of our data around the PKD is the number of patients who are on dialysis, because that's when we start recording the frequency. I know that it's going to be, as I said, I think it's the 4th here as well, the 4th most common cause of dialysis. But I think in Canberra, we have about 80 individuals, 80 or 90 individuals who have polycystic kidney disease that are treated through Canberra Hospital.